Now I'm going to take it back to our clinical advisors and reintroduce Delphine Tuot and Paul Gibney, who are always such a great source of advice and wisdom, as with their great many years and many e-consults that they've done themselves. And so with that, I think we're all back on now. We will, after a few words from Delphine and Paul, we'll hand off to Stan Frencher and Susie White, who will talk specifically to the Inland Empire Health Plan program. And we're back to the whole idea of provider engagement. So with that, Delphine and Paul, I'm going to hand off to you to speak to a couple of slides on your experiences today. And go ahead, Delphine and Paul, I think you're unmuted now.
Great, thank you. Before I get started, I just want to acknowledge how amazing of a talk Wando just gave us. It's really inspiring to see how eConsult, just part of a larger technology, can really be used to drive healthcare equity and health equity as a whole. So just really want to thank Wando for her talk and her inspiration. We miss her here in California, but it's great to see how much more of an effort or how she can disseminate all of her great work across the country and in the Midwest. So I'll just stop there and move on. As just using that sort of as our background, I think eConsult can be a cornerstone. It's not the only technology that can move us towards equity, but it's certainly a cornerstone of improving specialty care access for all patient populations, but most notably those in whom there is a supply-demand mismatch, which is mainly our Medicaid patients. And so we have seen that successful eConsult implementation in a variety of different systems requires a lot of different elements. And I think Paul and I wanted to talk about some of these elements in the next two slides. I think I'll start just describing this jigsaw puzzle, essentially, of the various elements. Starting at the top, we have seen that successful eConsult implementation in California, nationally, as well as internationally, includes executive leadership and support, commitment to ongoing improvements, ongoing QI, as well as clinical champions. And this is where I think Paul and I will provide some additional kind of input. And these includes both primary care champions as well as specialist champions. Efficient workflows, which I think was alluded to earlier in the payer discussion. Funding and payment models. So how can, who should be funding, or how can we achieve this technology for the FQHCs, for the specialist providers as well? Use of intuitive technology certainly helps. And then lastly, that eConsult actually meets your organizational needs related to specialty care access. This isn't true in all communities. In some communities, specialty care demand actually is below supply, right? But that's not often the case in the communities in which we work. So we know that these are elements for successful implementation. Paul, did you want to add any few comments here? If not, perhaps we can move on to the next slide.
Sure, and Paul, I think you're on mute. Let's make sure that you take yourself off mute. Are we able to hear you now? No, we're not. So we'll figure out your technical issues and we'll come back, Paul. So hold those thoughts and we'll come back in a moment. Go ahead, Delphine.
Great, thank you. And so the one thing that we wanted to hone on particularly today was provider engagement. We know, or we think, and we know that many providers are invested in health equity, are invested in access for their patients, but there's still a number of barriers to that, and the presence of some facilitators that we think we can help with. And so here's just a list of some facilitators and barriers that we have identified through our past many studies and many case series and case reports and system sort of evaluations. I'll start with some facilitators on the left-hand side, and it seems that Paul is now back on.
And I think I'm still on.
Great.
Can you hear me now?
We have you, yes.
Excellent, sorry. Can we go back to that first slide for just a minute? So, I wanted to echo what Delphine said. So many of the folks today have really hit on a lot of the key points, and a couple of things on this slide that Delphine created that I wanted to touch on is, many times people have asked, how did you select the first specialties? What was your recipe for success? And they thought that maybe it was specialty dependent. And looking at that yellow puzzle piece, I would say it was actually specialist and champion dependent. We started in 2012 with neurology and dermatology, and people said, well, why did you choose those? Well, it's because we had some amazing specialists that stepped forward, that intuitively saw the value of eConsult, had great ideas, and wanted to leap in doing this in a big system. And I think that was really the key, especially early on when you're struggling with proof of concept, trying to figure out how does this work in our unique setting, to find those great champions was really, really key. And then also figuring out how eConsult fits into the larger strategic goals of the organization. And I think that light blue piece kind of talks about that, trying to articulate where does eConsult fit in our priorities, our strategies, and our patient needs. Reflecting on what Nwando said, several of her core principles around access and equity, eConsult was key for us in LA County to try to figure out how to take specialty care and equitably distribute it across a very large geography and a very populous county. And so those were some of the things that we saw were really, and they resonated with our providers. When I would talk with providers, they really latched on to those things, identifying those burning platforms where our patients were struggling, were some of those real key elements. So Delphine, you can take us to the next slide, and thanks everybody for your patience with my audio issues.
Great, thanks, Paul. So building off of that, I think it's key that we try to maximize facilitation to use eConsults in our primary care and referral settings, and try to remove some of the barriers. And acknowledging what those are are the first steps, and then we can move forward towards trying to break them down and mitigate any barriers that exist. And so I think clear facilitators to eConsult engagement or eConsult use by referring providers is that there's a clear value proposition, right? There has to be a value to the primary care provider. I use primary care provider, but really any referring provider, whether a specialist or primary, would fit here. And this really includes access to specialty care. So we really need to be clear and transparent with the improvement in access that eConsult provides. Sometimes anecdotally, this is very easy, right? You get, as a referring provider, you get a response in 3 days or in 4 days or in 2 hours, and that can actually be really gratifying. But I also think transparency, help with transparency on access to specialty care locally, and this is where engagement with our health plans and engagement with local specialty groups would be really helpful, because it's also very gratifying from a clinical medical home, knowing that your access to neurology care has really improved over time as you have started eConsults. So I think the access piece is really key. And I think the other clear value proposition that we can keep honing on is that it provides education. It's essentially continuous, case-based, adult learning CME, right? I refer some of my patients as a specialist to other specialties and get responses back and really expand my knowledge. And we know from previous survey-based work that this expands knowledge, understanding, capacity, and comfort among primary care settings, as primary care providers as well. So I think those are the two components that I see as parts of the clear value proposition. But I think it's always important to just go back to make sure that this eConsult is valuable to referring providers, and we need to just hone in on that.
Yeah, Delphine, I would just add in on that I kind of knew we were onto something in Los Angeles when we rolled out eConsult very steadily and added specialty after specialty over a period of many months. And so there was this period of time where we kind of had a natural experiment, where we had PCPs that had some specialties available on eConsult, and then some specialties where they were going to an old paper-based system or faxes or one-way communication via an electronic platform. And that was the old way, and we had the new way in eConsult. And I knew I was onto something when I started getting dozens of emails from PCPs saying, When is nephrology going on eConsult? When is rheumatology going on eConsult? Because they were having such a positive experience, a high value experience with the specialties that were already on eConsult, that they were voting with their feet. They were saying, when are the rest of the specialties going to go on eConsult? And so that was an indication to me that we really did have a clear value proposition when we moved to eConsult.
Exactly. And so I think other facilitators, just in the interest of time, I'm not going to spend as much time on, but I think engaged leadership, I think role models are really key. This includes, of course, the executive team, but more importantly, I would say includes provider champions, right? This is your primary care provider that everybody trusts. This is your specialist who everybody goes to with curbside advice. So these are the individuals who, if you can reach out to and try to get their buy-in and their understanding of the value, then I think that will in itself go a long, long way. I think we have seen that locally in San Francisco, and I think, Paul, you have seen that as well in your setting. And we have identified that in other successful implementations as well. I think along with that goes with established or trusting relationships. If you're using local specialists, trusting relationships with those specialists is helpful, because you know that the information that they are giving you back, or the recommendations that they are giving you back, are recommendations that you can trust and follow, and you can reach out later with further questions. I think trusting your vendor, if they're not local specialists, is always very helpful. And most of the vendors now are doing really great quality assurance with their eConsult responses and eConsult specialists to ensure that the consults that are coming back are high value, are educational. And then lastly, I will say sort of team-based, efficient workflows, efficient technology. We can never, this is not eConsults are, we kind of keep it in the technology bucket, but it's really at its foremost communication. But you want to make that communication most efficient, most patient-centered. And so really creating team-based workflows to try to make that as efficient as possible is really helpful, leveraging other members of the healthcare team. This includes referral coordinators. This includes medical assistants to whom you can then forward an eConsult response and say, can you get these labs that were recommended by the eConsultant, et cetera.
Yeah, and I think that when we look at the barriers and the challenges that we face, certainly this is something new, and every doctor practices differently, and every doctor has different concerns, and so when we look at those barriers and we look at clinician resistance, sometimes it's an unfamiliarity or an uncomfortableness with this new way of doing things, but also sometimes it's just an uncomfortableness with the actual workflow. Like, how do I fit this into my regular day? Or is the technology working for me? Or what do we have? What if me and the specialist disagree? Or what if the PCP doesn't give me all the information? Or what if the specialist does something different? Where is the liability in that? And then just kind of how do I get supported to do this in my system? How do I get reimbursed? And so as we have engaged providers, we've had to address each of those barriers, and we don't have time. Delphine and I, maybe Stan and Susie can talk with them a little bit as well. But but what I would say is something that has helped me in talking with our providers is helping them see that this truly is patient-centered care. That when a specialist and a PCP are talking and coordinating and collaborating, that is a win for the patient. And so one of the things that I challenge people, especially as a PCP myself, is that this is what a patient-centered medical home means. This truly is patient-centered care, and sometimes that means taking on these conversations because you're advocating for the patient and because you want them to have that most collaborative and most and cleanest transition to the specialist in the best way possible, whether it's via eConsult dialogue or whether it's other things. And so we wanted to pause there and move on to our awesome panelists. We've got Stan and Susie from the Inland Empire Health Plan, which takes care of over 1.2 million people in the Inland Empire. I've worked personally with Stan at length over many years, and so I'm grateful for him. And Susie, I know that you have done a lot of really innovative leadership previously to your current role as COO and currently in your current role. So Libby, if you wanted to say something more to introduce Stan and Susie, I will turn it over.
I think you did a great job, Paul and Delphine, and thank you so much for your great experience, your comments from your great experience. And I know you know a lot about our Southern California friends in Inland Empire, and thanks so much, Stan and Susie, for joining us today. Susie White, as COO from Inland Empire, has such great experience from the plan perspective, and Dr. Frencher, being a responder, or an eConsult responder himself, will be able to share some of those experiences. So, Stan and Susie, I'll project your slides for you, and Susie, I'll let you take it away.
Let's see if you can hear me.
Yes, we can. Oh, now you're muted, though. Come back, Susie.
Okay.
Now you're good.
Hold on, I'm having computer issues.
No problem. I just want to note that we met you probably 5 years ago, Susie. It was great to just meet you at the outset of your program, really hear all the different perspectives, as this was so new. And having your program grow so quickly has been really exciting and a great example for all. How are you doing audio-wise?
It's gone fast, but also very slow.
I wouldn't say that.
So,
I think you're good now.
Okay.
Go ahead and let me know when I can click forward for you. Go ahead.
So we actually kicked off our program in 2017 in the fall, really bringing in our 2 counties to support us. So we support Riverside and San Bernardino County. So that's where we started. Both county systems wanted to do eConsult, and we said, hey, we're going to jump in with you and let's do it together. And so what IEHP did was really start the initial funding and brought on a consultant, but they actually really became part of our team, Wise Healthcare. And so we could not have implemented this without a team because this was very new to IEHP. And so these numbers really show where we're at today. We've had 80,000 eConsults, and we're at 93 clinic sites. So this has been really a lot of work, but we have a lot more to go. We currently support with 44 specialties, and we have 569 primary care providers, and that includes mid-levels also. And we have 100 specialist reviewers today. Next slide. And this really shows how we are spread out across our 2 counties. So we represent the different groups. Blue would be our ARMC, Arrowhead Regional Medical Center, so that would be our San Bernardino County group. Purple would be Riverside University Health System, so they have a lot of FQHC clinics scattered across Riverside County. And the red would be the IEHP, what we call the IEHP clinics. Now, all of these members are through our directly contracted network. And so we separate them kind of into different networks, but really from our eyes, it's all IEHP direct. Now, we do have a large delegated network. We actually have really just stayed with our direct network at this point. Next slide. So this really shows where our growth has been this year. And as you can see, April, we all knew what happened in April with COVID and the lockdown. So obviously all visits really dropped with primary care doctors. So there was less eConsults happening. But we're actually really picking up now again with those visits. So you can see in our different networks, the orange would be our IEHP clinics. Blue would be our San Bernardino Arrowhead clinics, and the raspberry color would be our Riverside clinics. Next slide. So this really shows our percentage of eConsults that are non-face-to-face. So April obviously was a big spike in non-face-to-face. So that was good, but then it leveled out a little bit. So we're going to get back up to that goal of 17.6. We're going to surpass that, I hope, in December. Really, we want to get to the 20%. So I think it's steadily going up as we move through. And this is really hot off the press. We just got this information last night or this morning to show the survey that was done on our providers, our PCPs and specialists. And so interesting, the specialists really do like it, and it's easy to use. PCPs, I think a C grade is pretty good. Definitely we have some improvement to do. For PCPs, you know, fitting well into the way they work, 47%. I mean, it is a big change in practice. And I think that's been some of our learnings, is how we rolled this out to the providers initially is really changing the way they practice. I think from a health plan standpoint and looking at providers, it's really easy to submit referrals for a member who comes in and says, hey, I want to go see this specialist or that specialist. And an eConsult really asks for a lot more commitment from the PCP, really engaging around, does this member need this referral? Is it the right thing for the member? Does the member have the right workup? And so it's changed the fact from just submitting referrals to really thinking about, is this referral required? And did we do what we needed to do to get this member to the specialist? So I think that's been an amazing change and really changing the thinking of a PCP, which is what we're trying to do here. Is that my last slide? We can get rid of the slides. Let's just talk. So I think for us, really why we started eConsult as a whole, at the time Dr. Gilbert and Jennifer Sales were here, they thought it would be a great idea. We have had huge impacts in our specialty networks, especially with our 2 counties. And so that's really why that partnership there started. Like most Medi-Cal health plans, high no-show rates. And so that obviously is a problem both for the member, but mostly for the specialist, because they're taking up slots that other people could be using. So how do we really align the payer, the providers in this whole network? So we really started out with the 2 counties, and they were our first initial customers. And so part of that engagement was a little bit easy because some of them are employed physicians, but very quickly outside of that, we got to our PCP clinics, and those are not employed. They're mostly capitated providers, and they wanted to know, why should I do this? We really picked providers that we had good relationships with as a health plan. They'd been with us a long time. They had high referral, so high membership. And so there's a few of them that we had done some practice transformation work. So they seemed like really good candidates to start with, PCPs that could be PCP champions and really support the message. So that's really where we started with it, and then really have expanded. Initially, with our specialist reviewers, we utilized primarily the specialist reviewers out of both counties. And that was beneficial because they were in the system, they knew it, but we did identify some opportunities in those relationships. Like, I think eConsult brought out a lot of things that showed you broken pieces in the whole system. Referrals going through that didn't need to go through. Definitely when we looked at these community specialists through the county systems, we had providers that we didn't know. They had never been credentialed and contracted. I mean, just things that you know already happen, and they were just escalated, you know, because then you're like, wait a minute, you're not with our plan. And so things we found through the process, I think helped us to shift. We have actually changed, and I'll let Dr. Frencher talk about this a little, but we did change the way we actually operated our specialist reviewer network. We made a change in July, which has been very beneficial, I think, for the health plan, our expectations for our specialist reviewers, but there's a lot of opportunity still happening. So I think one of the things that has really been beneficial for us is, just like I've heard all morning, is really the leadership supporting the process. You're going to get in with providers. There's going to be some that love it, some that are willing to do it because we have a good relationship, and we have some providers that absolutely don't want to do it. And so we've actually had one provider who I would say quit us, not as a health plan, but as eConsult. So I think that's pretty good. We actually didn't roll it out as a mandatory program. We kind of just said, hey, this is what we expect you to do. And through the process, we've actually identified things that would make it easier, that the WISE team and Dr. Frencher would observe, the direct authorization process for some of the diagnostic testing. So there's things that we're constantly reworking in order to make it more acceptable, I would say, to the PCP. But yes, we don't say mandatory, but we're like, hey, we want you to do this. What we find sometimes is they'll figure out how to work around it by faxing in referrals. Not a great thing. So we're always trying to figure out how to work with that office. There's a lot of rework going back. You know, primary care offices have a lot of turnover, so there's a lot of training the staff and working with them. But I think we have a pretty good footprint, but we don't have everybody on it yet. So we still have a lot of work to do. So Stan, do you want to talk about some of your side of it from the beginning to where we are now?
Sure. No, that was great, Susie, and what a great summary. And it's been absolutely phenomenal working with IEHP, and helping to engage with both their primary care physicians and specialists. I'll just take a step back just for context. I first met Paul and first was introduced to eConsult as a clinician, having finished at Yale and had a background focused around social justice and inequities and health disparities throughout my training as a clinical scholar and even all the way back to undergrad at Michigan. So I still love you, Nwanda, despite the fact that you're at Ohio State. But I think that what we both share is this passion for trying to improve care in underserved communities. And that really stems from my growing up with a primary care physician as my father. And he still practices in inner city Detroit, even in the midst of his current illness. And he was one of these guys who was reluctant to engage in telemedicine. And he represents a good majority of the docs that we run across, particularly as we started to engage with physicians in small practices in the Inland Empire. So for those who don't know, over half of physicians still practice in small practices, less than 10 providers, over 50%. And many of those, still over 50%, are physician-owned practices, either by a single physician or by an overseeing physician. And so the experience I had in academic medicine, training at Yale and then coming here to UCLA, was vastly different, than the experience in interacting with physicians in the Inland Empire. It was similar to that of the county when I was at LA County DHS working with Dr. Gibney. But if there's any message that you take from me today, it's context matters. When we do any of these implementations or any of this work, context matters. And so been in county facilities, been in academic institutions, now I've implemented in correctional health facilities, implemented in state hospitals, and now working with the physicians in the Inland Empire, context matters. And so what I mean by that is when we started to work with the specialists initially and the primary care doctors, we had to engage with them as individuals. We reached out to physicians who were leaders, worked with their leadership to identify those specialists who were the go-tos that Dr. Gibney talked about. Who were the guys who influenced all the other physicians and the way that care was delivered? But beyond just knowing who were the champions, we had to know who actually oversaw and managed other docs in the care. So when you go into these other environments, there's not one single CMO who's making the decisions about how specialists and primary care practitioners practice. It's often leveraged by different contractual relationships with medical groups, sometimes with individual docs. All of those play a role in incentivizing or disincentivizing the physicians to participate in something like eConsult. So again, thinking about the context in which the docs are practicing, I think is key when engaging physicians in doing something like eConsult, because it's going to impact how they view the value. And so we talked a little bit about value proposition earlier. And so yes, from a clinical perspective, we see a tremendous amount of value, right? Patients are able to get in to see us sooner. We're able to understand and see, the workup completed more efficiently. And that was something that every single specialist we talked to was totally bought in on. They're like, totally, Stan, that completely makes sense. My life as a specialist will be better with eConsult. That said, how does it impact my compensation? How is that going to impact the number of visits in my clinic? How is this going to impact the way in which I'm reimbursed or compensated based on my current contract? And so those are still things that have to be addressed in the process of trying to implement eConsult across a diverse group of providers. In a staff model HMO or in a closed system, very different than in this very amalgam of different types of providers. And so I think that was one of the early lessons we learned, was that it was a combination of understanding the individual practitioner's motivations, as well as the systems in which they practiced and those who led those practices, which was a key. I think the other thing beyond how were the docs employed is, and how the docs are paid, are how are you going to train physicians in using this? The notion that we just give docs technology and they figure it out, which is kind of what I landed into when I started using certain technologies, and what we often expected folks in the midst of COVID to do. Here's Doximity, go ahead and start seeing patients by video. It truly matters how you go about training the docs. And so that was a big part of what we brought to the table, both from the experience that I had as an individual practitioner in LA County, practicing, being on one of the work groups that LA County put together to help establish eConsult. I think that was sentinel and key, having primary care docs and specialists working together early on to understand how they aim to implement eConsult from a clinical perspective, but also work groups from a technical and from a workflow perspective, so that you're able to understand how it's going to impact the individual clinics, as well as how is the technology going to be implemented and where are the gaps from a current state perspective. And I'll take you to my next point. I think that a big part of the success in LA County, as Paul had alluded to, is what was the current state. Right? So when I arrived as a newly minted resident, now attending, having only been on Epic and on CPRS in the VA and only touched electronic health records because I'm a little bit on the young side, walking into an environment where I was now on paper was a little bit daunting. And so being able to have transparency around where my patients were going when I referred them to a radiation oncologist through eConsult was tremendous. It was life altering versus some of the contexts in which you implement eConsult where maybe they already have an EHR. Maybe folks have already experienced eConsult. Maybe they've had a bad experience with a different eConsult initiative. So understanding what the current state is in the areas in which you're implementing with physicians is also a key factor. So spending the time to educate yourself about what's going on in those clinics. And that's what we did in the Empire. So a big part of our approach was to go out to the clinics with our workflow engineers, understand current state, go over with both the clinic, the physicians, and the leadership, kind of what future state would look like in the setting of having eConsult as part of your workflow, and then going back to revisit with those clinics to iterate over time, and learn from that process how to better implement it moving forward. Like Susie said, it wasn't a mandatory approach, but it is analogous to what I've heard already. And I think the phraseology we used was eConsult first. So really utilizing eConsult as the initial way in which you reach a specialist, as your workflow in accessing specialty care. That didn't mean every eConsult would result in a face-to-face, or every eConsult could lead to the patient having their care taken care of remotely. But I think it was key to know that that's where you started first. And in doing so, encouraged a lot of physicians to use that as their primary approach to addressing their patient specialty care needs. I think there was also a mention of, one of the other most important tenets of what we were doing is managing the physicians, right? And so what I mean by that is helping to review all the eConsults that come through, helping to provide immediate and periodic feedback, so that from the specialist side, that we're providing value to the primary care docs, and from the primary care physician side, understanding what some of their challenges and barriers are as they begin using the process, ensuring that their clinic staff understand the process and are using it appropriately. As Susie talked about, are they trying to figure out workarounds because they dislike the process? And are there ways to mitigate that by addressing some of their high needs, for diagnostic testing or particular specialties that they find that there may be less value in using eConsult? How do you provide them examples as to how to use it better? So I think going back to folks and making sure that they're using the tools appropriately and that the docs are engaging well, is critical. So it's not something you can just drop off. and train early, and then hope that folks continue to use it well, I think it's something you have to continually go back and oversee and manage. And I think what Susie had mentioned was what we learned also from a context perspective is probably something that is analogous to what UCSF is doing with pediatrics. Like, it was mentioned that sometimes having docs who are not seeing the patients in person is helpful and beneficial. And we found that and thought that. I think that my gut sense was having docs who are agnostic provides a balance to those who see the patients in person. So when seeing a patient in person, you have the added benefit of making sure the workup is there, that there's consistency across the advice that's been given, and that ultimately the specialist who ultimately sees the patient will be the same one that you provided some advice to. And in LA County, that's very much the case as they cluster the specialist with many of the primary care docs. And there's a tremendous advantage to that. That said, when you have not a closed staff model, HMO, or kind of an employed model, you have a number of docs who maybe pay fee for service and are incentivized to ultimately do the consult and maybe see the patient as well. And so by having agnostic specialists who ultimately are only motivated to provide the best advice possible and help coordinate the care as best as possible, it provided, I think, an opportunity to further provide a greater value to the primary care docs, as well as provide a check on how the tool was being used. And so from that perspective, we ultimately transitioned and because of the gaps that we saw an opportunity to bring to bear docs who we knew, me personally, who were mission driven, focused on improving care and a safety net and access to specialty care, and who were just simply talented, board certified, and oftentimes affiliated academically, or were just great clinicians, and recruited them to provide this kind of care, and formed a medical group, a virtual medical group, HubMD, to support the Inland Empire Health Plan, and now support many other clients as they implement eConsult. Because one, it allows you to quickly bypass, at least on the part of the specialist, the need to have specialty recruitment from your own network, as well as ensuring that you have experienced and talented folks who are providing eConsults or specialty reviews. So I think that, and that doesn't necessarily preclude us from working with the local specialists to see patients in person. In fact, combining the two, we have seen, has been probably the best approach, in terms of providing that kind of access. So I think those are kind of the highlights that I wanted to talk about in terms of engaging with physicians. And I'll just say lastly, before I go, is just that, I look at my dad and see the evolution that occurred as a result of COVID and his own illness. And, one of the best pictures I have that I keep in my office is him sitting in front of a computer terminal now, taking care of patients through virtual care, when he wouldn't even allow them to bring a computer into his office. And I think that the value of that and that he has seen is something that we can translate to other primary care doctors and specialists who may be resistant to using something like eConsult. So with that, happy to take any questions. But yeah, it's just been a fun experience working with Susie and the rest of their team. And so thanks a lot.
Thank you so much, Dr. Prunter. I have one question that's come in for the IHP team, and then we can take some general questions around provider engagement. Our first question for IHP is, what time period were you referring to in your deck around the number of eConsults? And
that's as of this month.
Right. So is it for a 2-year time period?
Oh, since last July.
Great.
We started last July.
Thank you. And then how much of your membership is eligible? What % of your membership is eligible for eConsults in that time period?
Probably 30% of the membership.
Great, Thank you.
Because
so
it's not all
we're
directly contracted, but we're starting there.
Great. We have some just a few minutes for some questions, and if you'd like to offer them through the Q&A, we'll open up to the Q&A.
Libby, I saw on the Q&A from Joel just a question about how do you help eConsult be viewed as a facilitator instead of a barrier, and I think really the way I've done that is kind of walk through the experience of the usual process, where a one-way request is sent, a patient arrives at the specialist, they haven't had any of their pre-visit workup, they haven't had their requisite labs, they haven't had the requisite radiology studies, and then they kind of burn that visit with the specialist so they can have a definitive second visit with the specialist after all that is done. And it's a real waste of the patient's time. And so by having a pre-visit consultation to get all those regular labs or studies or tests, so that when they do arrive for the specialist, they actually have all the data the specialist needs to make a definitive conclusion and next steps is really high value. And that's far from a barrier. In fact, that's very respectful of the patient's time. I didn't know, Stan or Delphine or others, do you have a similar view or other anecdotes of how eConsult is a facilitator, not a barrier?
Yeah, I would completely agree. I think another thing that we should just be cautious of or be cognizant of is we really need eConsults to be available to an entire patient panel or an entire provider's panel. That way the activation energy essentially to submit an eConsult is much lower. You don't have to think, oh, does this patient qualify or is this patient non-eligible? And I think we're all working towards that. But in order to respect the patient's time, right, in order to respect the ability, the access to specialty care for all of your patients, I think that's key.
Yeah, I think that's where IHP was kind of a leader in terms of their implementation. They offered it to everyone, like all of the patients in the primary care physician's clinic. Now you have to go a step further, because depending on the percentage of patients that you have who belong to that health plan may still result in how the docs end up utilizing it because of the differences across plans and across payers. And so I think that goes back to a comment by Joel. The more likely you can get folks to cooperate around a singular approach that reaches out to the whole clinic, like on behalf of several payer types, like I think you have a better chance of getting that provider to implement the process like smoothly. And so that's going to require that word that I'm sure I can't pronounce either, that co-optation.
Thank you so much, Dr. Brunter. I have one more question before we need to wrap up our discussion, and thank you so much for your time today. Delphine, this one's for you. Have you come across some hesitancy from PCPs to adopt the specialist guidance based on eConsults? The comment is hesitancy may come from increased liability or exposure for PCPs performing this management, specialized meds, ordering complex tests. Do you have any thoughts on that?
Yeah, I would love for others to chime in as well. We have not seen that, particularly because I feel as though we really want to make sure that the specialists are providing guidance and also anticipatory guidance. And this is also really meant for patients to receive, I don't want to call it low-level specialty care, but the specialty care that everybody feels comfortable that a patient receives in primary care. It's really to raise the capacity of primary care. It's not to replace, essentially, specialty care in-person services that should be done in person. Really, it's to better triage, better match what the patient needs. And so I think in that respect, patients get what they need in primary care settings with specialty care guidance. And also, we've come across numerous situations where a primary care provider will ask a specialist what needs to happen next or ask a question, and the specialist recognizes actually a much more urgent consult on the back end and says, actually, thanks for reaching out. We need to see this person yesterday, right? And I will urgently schedule them for next week. So it's really an ability to just identify where the patient should be seen. So when done well, and this is where guidance for specialists as well on how to do a good eConsult, I think is key. We haven't run into those issues.
Yeah, and the beauty is from the primary care perspective is if the specialist is giving me guidance that I'm unfamiliar with, asking me to use medicines or things, it's a dialogue, right? And I'm able to say, wow, that sounds really important. I've never used that medicine before, or I don't know how to interpret that study. And then they're all like, oh, yeah, I didn't realize that. Hey, we'll take it from here, or we'll do the appropriate next steps.
Yeah. I think you're on mute, Libby.
And I'm still on mute. Dr. Frencher, go ahead.
Oh, yeah, no, the only thing that I would add is that I agree with both Dr. Gibney and Dr. Tuitt, I mean, I think that, there's different perspectives in terms of good e-consults and good dialogues from a primary care and a specialist perspective, and both require important input and feedback. And one of the things that we have noticed is that in the use of e-consults, as it's been implemented by different vendors and different types, leveraging staff to submit e-consults, like I would suggest, is maybe a break in the process that makes it difficult to get high quality clinical vignettes. So if there's one pearl I'd like people to take from today, is that it's important that primary care docs and specialists are engaging in an actual dialogue, because oftentimes what I've seen in multiple networks is that those submissions that are absent a primary care doctor's involvement lead to very kind of suboptimal clinical vignettes, almost cutting and pasting of progress notes, like that ultimately, I think, breaks down what is the spirit of doing eConsult, which is care coordination between the specialist and primary care doc. So I think that, one pearl that I would suggest, and again, everybody implements somewhat differently, I think that at the heart of it, it's really good clinical information from a primary care doc going to a specialist with a really great response, anticipating needs, and providing feedback.
Thank you so much, Stan. And I'm gonna wrap up our panel. I know we have some other comments coming in. Please keep those comments coming, and we can share them with Susie, Stan, and Paul and Delphine too. Thank you, Susie, for sharing your program. I think it's been a great example for other collaborations across the state, and I hope you all have a great day.